Good evening, everyone, and thank you for joining us for tonight's webinar, Improving Patients' Outcomes with Rectal Cancer and Addressing Equity and Access. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and future. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. Our first speaker tonight is Associate Professor Matt Rickard, who is a colorectal cancer surgeon at the Concord Cancer Centre and is the chair of the Colorectal Surgery, Concord Clinical School and University of Sydney. He is the immediate past chairman of the Australian and New Zealand Training Board of Colorectal Surgery. He is the head of the Department of Colorectal Surgery at Concord Hospital in Sydney and a colorectal surgeon at Macquarie University Hospital. Associate Professor Rickard will be presenting on symptoms, diagnosis and guide of the optimum pathway. Thank you, Matt.
So thanks for the introduction. So as Rebecca said, I'm a colorectal surgeon, work at Concord, and I'll talk briefly about the symptoms of bowel cancer, how we diagnose it. And this is about equity and access. So I'll touch on some problems with access to treatment and access to diagnosis. So to begin with, this is what a cancer looks like on a colonoscope and also on a barium enema. So that picture on the right is the classic sort of apple core lesion. And the picture on the left is what we see when we do our colonoscopy. So you've got hopefully you can see my mouse. This is sort of normal mucosa at the top, and then you've got this ulcerated lesion with raised edges here. And I think, I'm not sure who's in the audience really, but I suspect that most of us would have some personal experience with bowel cancer, either a relative or even may have had it ourselves. It's very common. By age 85, 1 in 11 men will have some form of colorectal cancer and 1 in 16 women. Breast cancer is the commonest cancer in women and prostate cancer in men, but because bowel cancer is the second most common, it's the commonest overall. So it's very relevant to all our lives and practices. The classic colorectal cancer symptoms, and these are things that I ask all my patients every day when they come to me in the rooms with their problems. The classic things are bleeding, change in bowel habit, abdominal pain, and weight loss. And this, it's important to realize there's differences with the right and the left. And the analogy I like to give is when you've got a cancer on the right side, the right colon is big and capacious, and that's a picture of the Sistine Chapel. So it's a bit like having your kids in the Sistine Chapel and they can run around and not cause much trouble. In the cecum, you can have quite a big cancer and it won't cause any obstructive symptoms. So it can bleed away slowly. They can present with anemia or possibly a positive fecal alcohol blood test, but they can get quite big before they cause symptoms. On the left side, the left colon's a lot thicker and smaller, so it's a bit like having your kids in a phone box, so they'll tend to present a bit earlier. You'll see the bleeding, you'll have obstructive symptoms a bit earlier. So they're quite different right and left cancers. This is a picture showing the distribution of cancers around the colon, and I don't expect you to look at all the deets, but basically most cancers are in the rectum or the left, and it's less common in the transverse and the right colon. And specifically today, we're talking about rectal cancer. And a lot of you probably don't realize this, but the rectum is a beautiful thing. And it's like a lot of things in life, you don't really appreciate it until it's gone. And I'm not sure if people will be interested in this, but thoughts for the chat function. What other things in life do we not appreciate until they're gone? Maybe our children when they leave, maybe other things. And the reason it's a beautiful thing, and this helps you to understand the surgery that we do. The rectum is normally a big capacious reservoir. So you don't keep your poo in your rectum normally. You usually keep your stool further upstream, and when you eat or sometimes when you get up, then the stool is delivered to the rectum. And for the rectum to act normally, it has to be soft and floppy and be able to contain the poo. It has to be able to expand, and the nerves that go to your brain tell you that you need to go. You also need to have a sphincter here that's holding on to things. So this is why the rectum is a beautiful thing, because it's a reservoir. And when you lose that reservoir, it causes significant sequelae. And just to explain the symptoms, if you think of that reservoir, if you suddenly plonk a cancer there, and the cancers grow like this, and then the reason they bleed is because the central bit becomes ulcerated because you have abnormal neovascularization. So it kind of outgrows its blood supply, and they bleed, and the blood comes right out. And because it's usually fresh blood, it often gets mistaken for hemorrhoidal bleeding, and it often gets explained it's hemorrhoidal bleeding because it's fresh outlet type rectal bleeding. So with a rectal cancer, the tumor is very close. The other classic symptom is tenesmus. And this is that feeling of incomplete emptying. And this also helps you to understand that when you've got some feces here and you pass it, you might feel that there's still something there to pass. And the reason is because there is. So these bits will sort of push onto this section of the bowel, and that'll send the message to your brain that there's still something there. So the patients will feel like they haven't completely emptied their bowel because they've got this thing there that's still there, that's telling their brain something's there, but it's actually the cancer. So tenesmus is a very important symptom of rectal cancer. Now, I like to put this slide up just because it breaks up talks, but I wonder who can see the intruder in this picture. And for those experts at anuses, they would have also seen the anal fistula. There's a few of those type of slides. So we were given some learning objectives tonight, and one was to understand the rectal cancer optimum pathway during rectal cancer treatment. So, and I'm happy to be interrupted here, but what I thought I'd talk about was the ideal situation, and then perhaps some barriers that you as general practitioners might encounter along that pathway. So ideally, you'd have a patient come in with a suspicious history, and you would do a rectal examination. I think it's still relevant doing a rectal examination in your rooms, because certainly if you feel a rectal cancer, it gives you a lot more oomph in terms of getting that patient a prompt colonoscopy, which is the next step. So a prompt colonoscopy and then a prompt referral to a colorectal surgeon. And at that stage, he or she would organise appropriate investigations, which basically includes a CT scan of the chest, abdomen, and pelvis, and a pelvic MRI. So that's the ideal situation. In the ideal world, the patient would come in, you'd be suspicious about their history, they'd have a colonoscopy the next day and go and see a surgeon the next day, and then they'd have all these tests. Now, we know that those things don't happen that quickly, and I guess what can we do to make them happen more quickly? And MRIs, I won't bore you with lots of MRIs, but this is a classic rectal cancer with a sagittal view and an axial view. And you've got your rectal cancer up here and your mid-rectum, you've got your cancer here, and you can sort of imagine it's at the front kind of eating its way through there. So you've lost those tissue planes at the front. And this is an anterior tumor, which is T3 because it's gone through the muscularis propria, and there are some suspicious lymph nodes as well. So this is the classic cancer that we would get an opinion from Roya about having some radiotherapy before surgery. So which bits of this ideal pathway do you have trouble with? And I am interested in your experiences here. I imagine that you might have trouble with access to colonoscopy, and perhaps even deciding who to send for a scope. I mean, do you send every patient with rectal bleeding for a colonoscopy? Do you do it based on age? It's quite interesting to think about the same symptoms in a 35-year-old or a 45-year-old or a 55-year-old, the same symptoms depending on ethnicity or whether you're dealing with an Indigenous person. How do you decide who to send for a scope? My basic kind of rule of thumb for who has a colonoscopy is the age of 40. And that's sort of practically based, and you'll certainly have patients who are 35 who have a bowel cancer, and you'll have patients who are 55 who are just bleeding from hemorrhoids. But once you're over the age of 40 and you're bleeding, I think it's reasonable to have a colonoscopy. So access to colonoscopy, if you guys do have difficulty getting patients in for a colonoscopy, I guess you need to realize there are pathways, and I suspect you're all familiar with health pathways, and there is a thing called direct access colonoscopy, which is relevant in our area. So if you scroll through health pathways and get to this page, you actually can organise a direct access colonoscopy at Concord and at RPA. And for some reason, St. Vincent's is on there as well. There are also rapid access colonoscopy. Most of us in our private rooms certainly have rapid access processes, and we certainly have that at Macquarie as well. So I think I'm aware it is sometimes difficult for patients to get to colonoscopy, but there are pathways, and that's the obvious diagnostic method for rectal cancer and bowel cancer. Other problems you may have is access to a surgeon. And I honestly think this should be solvable, certainly in Sydney, because we probably have too many colorectal surgeons in Sydney. So you should be able to get to one. And again, on health pathways, if you go along to the colorectal assessment page, there's a page talking about public and there's a page talking about private. In fact, the only public clinic is our clinic at Concord. And if you click on that number, that is the number for our clinic. So if you're worried about patients, they can be referred to that clinic. Also on health pathways, it has all our details with our private rooms. So it's all there on health pathways in terms of finding people. And you should be able to access a surgeon. So I'm hopeful that you can. The other potential problem in terms of access is patient reluctance. So I know people are reluctant to have colonoscopy because of the yuck factor and perhaps because of fear of colonoscopy. And I think, so it's important to know the person doing the colonoscopy should tell them these things, but it's important for you, if you're sending someone off, to be able to at least point out to the patient what the risks are. The risks are very low of colonoscopy. They're not zero. The perforation risk is probably around 1 in 2,000. People get bleeding only if they have something therapeutic done. And we can miss small lesions. Sometimes the colonoscopy is incomplete and they need to have something else like a CT colonoscopy. I think in terms of explaining it to patients, personal experiences are helpful. Like I've had colonoscopies. In fact, I had one 3 weeks ago. So I'm very adept at explaining to them how the bowel prep works. Billy Connolly's got a beautiful skit on colonoscopy if they want to YouTube that. So they're some of the problems in terms of access I see. I don't know if anyone's got any questions or comments about that side of things.
No questions at this stage.
Okay. So I talked about the ideal pathway and problems with access. In some ways, it's very simple. A patient with suspicious symptoms really needs to have a colonoscopy. And once they've had a colonoscopy, often then the immediate work for general practitioners is done. And then it's a matter of reconnecting with them post-operatively. And so in terms of treatment, surgery is the mainstay of treatment, but treatment sometimes involves radiotherapy and chemotherapy. And Roya is going to talk about radiotherapy, so I'll leave that for her. But there are 2 forms of radiotherapy, short course and long course. And chemotherapy is usually used post-operatively, depending on the pathology of the tumor, and usually based around whether the lymph nodes are involved. In terms of the operative terminology, because one of our learning pathways was kind of understanding what we do and understanding the correspondence. The basic operation for a rectal cancer is called an anterior resection. And it's a kind of weird name because it doesn't really describe the surgery, and it's historical because when people first started doing rectal cancers, they did it from behind. So they used to do this kind of sacral procedure and sort of chip it out from below. And then they started doing the operation from the front. So it became known as an anterior section, which is a kind of dumb name. And it's based on where the pathology is. So this is a representation of the rectum. And at the front, this is what we call the peritoneal reflection. So if you've got a tumor up here in your high rectum, we basically chop it off there and join it on. So that's called a high anterior section if it's above that peritoneal reflection at the front. If you've got a tumor in the mid-rectum, we do what's called a low anterior section. And the important thing here in terms of patient's function is the ability to leave some rectum behind. If you do this operation, that patient will have very good function because they've still got that reservoir that I was talking about. Even if you can leave a little bit of rectum, like in this patient, they'll have better function. When you've got a tumor right down here, by necessity, you have to do what's called an ultralow, where you do your join right at the anorectal junction. And those patients will have difficulty with function, which I'll talk about. These patients will often have a temporary ileostomy. So we use these with very low joins. We're more likely to do it if the patient's had radiotherapy. And if the patient has an ileostomy, they have that for 3 to 6 months, depending on whether they have chemotherapy. So it's important to realize this is temporary, sometimes called a defunctioning ileostomy. And the idea of this is that you give your joint a chance to heal. So everything goes into the bag and nothing goes past the joint. So it allows the joint to heal. And if there is a small leak, you often don't notice it because it'll heal itself. So it doesn't stop leaks, but it sort of minimizes the sequelae of leaks. And obviously, if you've got a cancer right down here into the anal canal, that's the sort of patient that needs a permanent colostomy. So that's when we do permanent colostomies. That's called an abdominoperineal resection. And those patients will have a permanent colostomy. And we don't do that often, but sometimes the pathology means it's impossible to get below it to join onto something normal. So in terms of problems after treatment, these basically comes down to bowel dysfunction, sexual dysfunction, urinary dysfunction, and recurrence and fear of recurrence. So these are the problems people have afterwards. And these are the sort of problems that you'll get involved with again, because basically once the diagnosis is made, it's kind of out of your hands. But I'm sure patients come back to their GPs with a lot of these problems looking for help. In terms of bowel dysfunction, there's a thing called low anterior resection syndrome. And basically this means any sort of disordered bowel function after rectal resection leading to a detriment in quality of life. And as I explained, with the rectum being a beautiful thing and a reservoir, the more rectum you can leave behind, the less problems they'll have with this, with LARS. There actually is a whole LARS score you can do. And the only reason I put this up is to mention the sort of things that the problems they have. So they have trouble controlling flatus, so they can have flatus incontinence. They might have accidental leakage, so they can have frank incontinence or just leakage of bits of mucus. They'll go to the toilet more frequently. And they'll have this thing called clustering. So they'll often go and they think they're empty and then they've got to go back half an hour later. They may have to do that 3 or 4 times during the day. And they'll have significant urgency. So these are things that we always explain this to patients beforehand. I really don't think they take it in that well, because when a patient's got a cancer, often I think the only thing they hear is cancer. And we spend ages talking to them about bowel dysfunction and operation side effects and all that sort of stuff. But I'm convinced a lot of people just can't go home thinking, I've got a cancer, I've got to get it treated. So sometimes they're not aware of these things beforehand, despite being told. The treatment for LARS is basically symptomatic. If they've got a lot of diarrhea, we can give them Imodium, and you can get the patients to kind of sort this out themselves. Some patients will just take an Imodium before they go out to lunch, or if they're going to the shops. Some will take it regularly, and often they kind of work it out for themselves. Generally with incontinence, sometimes this sort of anti-intuitive combination of Metamucil and Imodium is helpful. So sometimes I get patients to take Metamucil in the night, or Psyllium, which is the same thing, in Imodium in the morning. Pelvic floor physio, very helpful biofeedback. If it gets really bad, they can see one of our stoma therapists who can teach them how to do transanal irrigation. So basically in the morning, they get taught to put a tube in their rectum and wash out their rectum completely. And that often gets them through the rest of the day. Very rarely we'd use sacral nerve stimulation. And if it's really bad, we would do a colostomy or an ileostomy if the function's terrible and they can't live with it. Dietary changes, some of this is witchcraft really, but generally if they have smaller, more frequent meals, drink plenty of water, and don't eat foods that cause a lot of gas, that's actually helpful. And the patients often work these things out themselves, and what's good for one is not good for another, so they kind of encourage them to experiment and work out what works for them. Sexual dysfunction is, the way to understand that is if you operate in the pelvis, you're at risk of damaging both the parasympathetic and the sympathetic nerve. So the sympathetic nerves supply ejaculation. So if you damage those nerves, which is harder to do because they're easier to avoid, you can get retrograde ejaculation, which is fine unless you're actually trying to have children. If you damage the parasympathetic nerves, which is more common when you're dissecting very low down in the rectum, you can get impotence. And it's very important to talk about that with men beforehand. And especially if they're kind of borderline before the operation, you can certainly tip them over into full impotence, which is actually hard to treat. So it's very important that we explain that to them beforehand. This is another kind of breakup slide, but this graph, if you look at it that way, it looks like a duck. And if you look at it that way, it looks like a rabbit, which has nothing to do with rectal cancer. Recurrence and fear of recurrence. I think it is worth anyone treating these patients afterwards knowing what their risk of recurrence is. And patients are different. Sometimes patients just kind of are fearful for the rest of their lives, and every single symptom they have, they think is associated with a recurrence, and most of them aren't. Other patients kind of just get on with it and don't worry about it. And probably most are sort of somewhere in the middle. So it is worth, I think, knowing what the risk of recurrence is. So the prognosis of all patients with bowel cancer that we see, and these are recent, this is recent data, relatively recent. So your chance of surviving at least 5 years is 70% overall if you present with a bowel cancer. And you could see that because of improvements in both surgical technique, radiotherapy, and chemotherapy over the last 40 years, it's actually improved a lot. So this is one of the real advances. You can see that overall it was 50%, in 1990 when I was an intern, and now it's 70%. So that's quite an amazing improvement, really. And this is one of these complex graphs, but it's basically stages. So stage 1, stage 2, stage 3, stage 4. And you can see that, and this first column is 1 year, 3 year, and 5 year. And you can see that, as you'd expect, the 5-year survival goes down as your stage increases. So if you've got a stage 1 tumor, your 5-year survival is 98%. Stage 1 tumors, if we operate on them, they rarely get recurrence. Stage 2, which basically means that it's gone through the muscularis propria, but the lymph nodes aren't involved, still pretty good at 5 years. Stage 3, that's lymph node involvement, and this is usually because of chemotherapy and possibly some preoperative radiotherapy, still 71%, which is pretty good. And this is one of the attractions of treating bowel cancer, because it's very curable, unlike pancreatic cancer. Stage 4, once you've got metastases, this 5-year survival drops significantly. And that's overall. I'm almost finished, but one of the other things we were asked to do was to help understand correspondence from colorectal surgery, pre-post surgery. So I think that was partly why I explained what the operations are called. The other lingo that you might struggle with is, so we talked about operation names. So neoadjuvant treatment means before surgery. Adjuvant treatment means after surgery. There's a new thing which you'll probably hear a bit about in the correspondence, which is TNT. And this implies that in some patients, usually when it's quite locally advanced, we give the chemotherapy and the radiotherapy, both of them before surgery. And that's becoming a little bit more prevalent. You might hear us talk about complete pathological response, which is where we see a patient with a cancer, we send them to Roya, she gives them radiotherapy, and when we look again, it's completely gone. And there's a certain percentage of patients that will use this technique, watch and wait, which is basically in that situation where we review them before operating and it seems to have gone, then we can leave them alone, but we have to keep a very close eye on them. So that's called watch and wait for obvious reasons. Staging, which you might hear discussed, there's various different techniques. Dukes, which is the oldest one, the AJCC, which is for every tumor. And this is the one that was developed at Concord. But basically what you should know is it's stage 1 if it's into that muscle layer of the bowel but hasn't gone through. It's stage 2 if it's through the muscle layer of the bowel but hasn't spread to the nodes. And it's stage 3 if it's gone to the nodes, and stage 4 if it's spread elsewhere. So I think knowing about the risks of recurrence is relevant for patients. This was the other interesting learning objective, which we got for this talk: develop confidence in escalating patients post-treatment back to their treating team. I'm not sure what I meant to say with that, but what I would say is if you're not getting in touch with surgeons, I'd probably find a new surgeon, because we do have a responsibility to sort out our own complications, and all surgeons should feel that responsibility. So if you've got a patient you're worried about, I think you just ring the surgeon in their rooms, or you ring, I mean, if you can't find them in the rooms, if it's done at Concord, you can ring and ask to speak to the colorectal fellow. But you shouldn't have any hesitation in contacting surgeons after they've done an operation on someone, because it really is our responsibility. We all hate complications, but it's a sign of maturity of a surgeon, how they deal with those complications. And surgeons who run from their complications, shouldn't be surgeons, basically. So I think the time's up. I'll finish with that slide, which is just a slide that I love. Any queries or questions about that? I hope I tried to make that as relevant as possible for the audience.
Are there any questions? Well, it's just come through. Do all patients get discussed at an MDT?
No, but ideally, yes. Especially all rectal cancer patients in our unit will get discussed at an MDT. A patient with a sort of straightforward colon cancer that doesn't have any metastases on CT scan, probably not, mainly due to time constraints. In an ideal world, yes, but really rectal cancer patients do and should get discussed at an MDT. Yep.
Great. Any other questions? Thanks, Matt, for that comprehensive information on not only rectal cancer, but that comprehensive pathway guidance. That was very helpful. Our second speaker tonight is Dr. Roya Merie, who is a radiation oncologist at the Icon Cancer Centre at Concord and a conjunct lecturer at University of New South Wales. She undertook her radiation oncology training and fellowship at Liverpool and St George Hospitals in Sydney, then worked as a staff specialist at Liverpool Hospital before joining the cancer services at Concord Hospital in 2022. She specialises in treating gastrointestinal, hematological and thoracic malignancies with radiotherapy, and also has a special interest in stereotactic body radiotherapy and palliative radiotherapy. Dr. Merie will be presenting an overview today on the role of radiotherapy for rectal cancer in the neoadjuvant, palliative and organ preservation settings, and an overview of a patient's journey through a radiotherapy course for rectal cancer before, during and after. Thank you, Roya.
Okay, thanks Rebecca for the introduction. So Roya Merie, radiation oncologist at Concord within the Icon Cancer Centre. So today I'll be shedding the light on role of radiotherapy in rectal cancer management. I think, for your patients, you often, as Matt went through, a really good comprehensive overview of presentation and referral to colorectal surgeons, but often GPs probably do not know what happens afterwards in terms of the patient's journey as they go through their neoadjuvant therapy. So I'll just go through that with you and demystify some terminologies with regards to radiation. I might skip through a lot of some introductory slides given Matt's talk. Thanks, Matt, for making my job easier. But I think just want to highlight that it's an important distinction to know where the location of the rectal cancer is, because that does have implication on management, whether it's low, middle or high, and that's usually depending on the distance from the anal verge, which is the bottom end of the anal canal. Some risk factors for rectal cancer could be genetic. While this is the less common cause, but we often look out for potential inherited syndrome risks or familial predisposition, but also there's acquired risks such as diet and inflammatory bowel disease, particularly ulcerative colitis. I'll skip through the presentation and the incidence because that was nicely presented by Matt. and staging as well. So we kind of are now familiar with the TNM. But again, that's important because it does have an implication on which patients get or need neoadjuvant therapy for rectal cancer. Just to highlight on this busy slide that MRI is quite vital in the initial staging of accurate information on the TNM or the TN stage, as well as anatomical landmarks that we usually look at in order to decide what the best approach or the management paradigm for each patient. Such, example of important structures that we look at is what we that kind of fatty tissue that has all the lymph nodes and the lymphatics. So we look at any potential high-risk features in there, such as involved lymph nodes, and look at how far that margin of the cancer is, or the edge of the cancer is, from the edge of the mesorectum. We look at the peritoneal reflection, which Matt also touched on, because below the peritoneal reflection are kind of within the confines of the narrow pelvis and could be at higher risk of benefit more from radiation, as opposed from cancers that are higher up above the peritoneal reflection, where there is less role for pre-operative treatment. For rectal cancer could be used in various scenarios. So commonly we talk about the pre-operative role, and that's usually advanced stages, particularly if they're in low locations, so mid and low locations. The main benefit of radiation would be is improving local control. We, as a rule of thumb, we say that it kind of halves your risk of pelvic recurrence, because again, rectal cancers, as we said, it's within the confines of the pelvis, so it could be a bit more tricky to resect compared to the colon or the rest of your bowel, where there's a lot more space. So usually it reduces the risk of local recurrence, can improve resectability because it can downstage the tumor, meaning that it can shrink it in size and make it a bit easier for the surgeon to resect and clear the margins or the edges around that mesorectum. It could improve the chance of sphincter preservation. So Matt talked about how important that function is post-resection. If we can get the cancer to move to be downstaged and maybe improve that chance of rejoining the bowels more successfully with more downstaging of the tumor, then we could improve the sphincter function or the type of surgery. Sometimes patients could have local recurrence just as an only site of disease coming back, which could be at the site of anastomosis or within the pelvis. These patients often can have salvage radiotherapy to try and control their cancer. Radiation could also be used in the setting of oligometastatic disease. That term is used when there is limited number of metastatic lesions in the body, such as in the lung or the liver. If these lesions are not amenable to resection for any reason, then usually we could use ablative doses of radiation called SBRT, a special technique that we can use to ablate these sites of metastasis to control the cancer. And common use as well for radiation in rectal cancer is the palliative role. This is more for the advanced stages. Particular symptoms that are quite responsive to radiation are pain and bleeding. And in these scenarios, usually radiation is used in relatively low doses, relatively non-toxic regimen to actually just help with symptoms and quality of life. And then the new kid in the block is the non-operative management approach, which I'll briefly touch on, but there's more interest now in using radiation and chemoradiation as a definitive treatment for rectal cancer, while the surgery remains the mainstay, but there's some interest in trying to preserve this precious organ by doing this treatment and do what we call watchful wait approach for the advanced stages, or potentially as a definitive treatment in early stage cancers. This is not yet standard, but there's more and more interest in these. So for the pre-operative radiotherapy, the main benefit, which I've already talked about, is reducing local recurrence, improve resectability, and increased chance of sphincter preservation. There are two ways that we do radiation. We call them short course and long course. Short course is often over 1 week or 5 fractions. Each fraction is a session of radiotherapy that's given over 10 or 15 minutes from Monday to Friday. So on the same week, we finish the radiation treatment course, and that's called a short course, versus a long course, which is often given over 5 to 6 weeks of treatment, 25 sessions. That's every day, Monday to Friday, again, about 15 minutes a day. And this is usually given in conjunction with chemotherapy, often an oral tablet chemotherapy. And there are different scenarios as to when we use what option. I might just skip this over this page, but with these scenarios, usually, we look at different things. We look at the location of the tumor, how low the tumor is, how much downsstaging we want, how advanced the disease is. We look at the distance of the cancer to the edge, the mesorectal fascia edge that we talked about. And then generally, in general term, if the cancer is low risk, meaning very early, they can get away with surgery alone because the risk of recurrence is probably low. That does not justify the need for neoadjuvant therapy. If they are in the intermediate range, meaning that they've got some nodal disease perhaps, and it's a T3 tumor in a mid location that we do not need a significant downstaging before surgery, then patients can get away with a short course treatment. However, for more advanced tumors, we often look at long course neoadjuvant chemoradiation therapy, sometimes in a TNT fashion, which is what Matt touched on, which is the total neoadjuvant therapy, meaning that we're even bringing the chemotherapy to before surgery. So depending on the purpose, we decide which patients need radiation. If we're just really trying to improve the control of the tumor and reduce the chance of the tumor coming back in the pelvis, we could probably either use short course or long course. There are established trials that looked at these two approaches and compared them and found equivalent outcomes in terms of tumor control. If we are looking at downstaging, then long course is a better option. If we are, considering organ preservation in the really selected scenarios, then we can also use radiation, more so be the long course style treatment. So the concept of TNT, or the total neoadjuvant therapy, again, repeating that, saying it's bringing that adjuvant or the after surgery, the chemotherapy component that's supposed to be given after surgery, we bring it to before surgery. So we're delivering all of this treatment before. So why did people start thinking about TNT? So they found that patients poorly tolerate chemotherapy when it's given after surgery because they've been through surgery. They might, still be recovering or having complications. So the compliance rate or the dropout rate of adjuvant chemotherapy is actually quite high, which makes it hard to actually be able to estimate what the benefit is from chemotherapy. What we also found is that if we bring that chemotherapy component to before surgery, there is an increased chance of downstaging the tumor and potentially increasing that PCR rate that Matt talked about, which is the pathological complete response, meaning that we could increase that chance that the tumor disappears completely from the chemotherapy and the radiotherapy treatment, which can open the opportunity for non-surgical management or watchful waiting type management. The other thing with rectal cancer is that while, survival is, as we said, around the 70% on average, but the common cause of death really is distant relapse. It's the leading cause of death. So while we are able to control the cancer locally and in the pelvis, but often patients fail in other organs. So a concept of bringing the chemotherapy component to before surgery is the introduction of chemotherapy earlier on, so that we can potentially eradicate any potential micrometastatic disease early on, rather than leaving it until a few months of getting through surgery, recovery, and afterwards. The additional benefit potentially for TNT is that the need for ileostomy after surgery. For patients who would need this ileostomy or the temporary ileostomy, they often would need to wait until they've received all their chemotherapy and recovered from that before they can have the reversal operation. And this can have an impact on the quality of life and patient satisfaction. So if you can minimize that time by not delivering the chemotherapy after surgery, then that's potentially a plus. The only message that I want to get out of this slide is just to show a sample of trials that looked at using this TNT and to show that they've done it in really various ways. Some people used chemotherapy first and then radiation. Some people used radiation first and then chemo. Could be short course, long course, really different protocols, different ways that the TNT has been done in the different trials. So there's no one agreed on protocol for it, but the common thing or the common theme out of the TNT trials is that particular finding, the PCR or the pathological complete response, in some of the trials we've seen that the rate of that has almost doubled or more than doubled from, for example, 12% to 28% or 14 to 28. So it's kind of doubled the chance that the cancer can completely disappear. And it has improved what we call the DFS or the disease-free survival in some trials. And one particular trial has had a really impressive results in terms of the rate of the patients who were able to have an organ preservation approach because of the TNT therapy is nearly half of the patients in the trial, using different protocols, they were able to achieve organ preservation. And while these patients, went on to have watchful waiting after a clinical complete response, there was still a reasonably significant regrowth rate, ranging from 27 to 40% in the different sequencing of therapy, but they were all successfully went on and had resection. However, all of these outcomes are only at 3 years for most of these trials, so we're still relatively in the early days of really looking at these approaches, but it's definitely a watch the space treatment. So I think we looked at we discussed the pros of the TNT approach. So we've seen that it can improve the disease-free survival, doubles the PCR or the complete response rate, can open the opportunity for non-operative management. But the opponents of this approach say that there's been, different protocols used in different trials. So what do we use? The trials has yet to show any survival benefit to this approach. So that's still not there yet. People argue that there could be a risk of overtreatment because we often rely on the pathology results from the surgery to look at nodes, etc., to decide on whether chemotherapy is required. So we might be relying on just the MRI to decide on that, and that could have a risk of overtreatment. And we're still waiting on long-term results. Might skip over that. So the ASTRO, which is the American body for radiation oncology, with their guidelines regarding which patients should get non-operative management, given that this is an increasingly a topic of interest. So they only recommend that conditionally for patients who gets the chemoradiation and then clinically they achieve what we call a complete response. So they get assessed using scopes and MRIs, and if we think that they had a complete response, then they could undergo non-operative management, particularly if the patient declines surgery and is a very engaged patient who's quite motivated to undergo intensive surveillance. Or if the patient, if he is to require surgery, that surgery would be at the APR type surgery, which is the one that would require a permanent stoma, or a type of surgery that would result in really poor bowel function. So these could be, and they also kind of published guidelines on how do you surveil this patient, because there's really no clear guidance on what to do with these patients. So I'm not going to go through the details of that, but just to say that we luckily we do have a local trial that, for these patients that are considering a watchful waiting approach. I think it's best to do that within a clinical trial setting, because they will get that, follow up with the MRIs and the colonoscopies or the sigmoidoscopies within a trial setting, particularly given that patients actually are only they only qualify for one MRI on Medicare for rectal cancer. So any additional MRI on that program without a trial would mean an extra cost to the patient. Yeah, so my take-home message for the non-operative management is, if we are using the TNT for that intent, is to do it within a clinical trial setting, at least for now. So I'll go through a case study with you, just, as a GP, to really be able to visualize what it's like, or to know what it's like for the patient to go through a long course chemoradiotherapy journey for rectal cancer. So this is a patient who's 63-year-old lady. She's presenting with intermittent PR bleeding for 2 months, has got a past history of diabetes and hypertension, no family history of malignancy. She is non-English speaking. She lives with her husband and is reasonably fit and functional. I might use some of the chat function if people would like to kind of type what they would do in terms of what are the key things to really assess in history. We'll just move on. So we talked about change in bowel habits, tenesmus, the continence, bleeding, pain, constitutional symptoms. So the usual. And then on physical examination, we have to assess the ECOG status, which is really a functional status measure for oncology patient. That gives them a score from 1 to 4, because that does implicate or have implications on treatment fitness, or ability to tolerate different types of treatment. We examine the chest and the abdomen, and the PR examination is also important. On the blood tests, we check tumor markers, including CEA on baseline, and kidney function tests. And colonoscopy is the critical one to look up for the tumor in terms of the size, the location, risk of luminal narrowing or obstruction. You get a biopsy from the scope. They can get an endorectal ultrasound to assess the T-stage, particularly if they can't get an MRI for any reason. Looks at any other synchronous lesions. And staging is often with a CT and an MRI. PET is not routinely done or indicated unless there was concern on the staging CT for metastatic disease. So this patient had a colonoscopy, and that did show a malignant lesion in the distal rectum. So there's often a measure as to where the location of that lesion is. It's 2 centimeters from the anal verge. There was bleeding. A biopsy from the mass was consistent with adenocarcinoma, which is obviously the most common type of rectal cancer. And this is her MRI. Again, that shows the tumor here. So we look at the location of the tumor, the distance from the anal verge. She does have a lymph node, and you can see that lymph node sits very close to the edge of that mesorectum. Similarly, the tumor as well, she's got that tumor edging out anteriorly, again, threatening that edge. So this is a typical patient who would, highly benefit from treatment with preoperative radiation, given all of these risk features. So the low location, the tumor that's, threatening the edge of the cancer, so that means that, going ahead with surgery without radiation beforehand can carry a risk of what we call a positive margin, or not clearing the cancer completely. She would be at risk of local recurrence, and that node, and she's had a few other nodes positive. So usually all of these patients should and would get discussed in the MDT. We discussed her, and given her locally advanced disease, she would be eligible for that RENA trial that we talked about. So just use of chemoradiation or TNT, and then watchful waiting if she had a good response. Or if she's not on a trial, she would just go onto a long course chemoradiation or TNT and then surgery as a standard treatment. So this patient then gets referred to both radiation oncology and medical oncology for discussion on treatment. She did decline the trial. I think part of it is her non-English speaking background made the discussion quite difficult. She would have the discussion around the long course chemoradiation, which is 5 weeks of radiotherapy concurrent with a tablet of chemotherapy called Xeloda. Usually that chemotherapy tablet that's given concurrent is what we call a radiosensitizer. So it's not meant to really address the systemic disease as much as really make the radiation work better and stronger. So that's why we still, doesn't account for the systemic treatment for them. It's just a local treatment. So once the patient has seen the doctors and had a discussion about the chemotherapy and radiotherapy, usually that follows on with a session that we call it the RT simulation or planning session. So that's the radiotherapy. It's like a preparation session where patients get scanned, measured, and then there'll be a lot of behind the scenes work that we do after that session where we actually design the treatment plan for them, and I'll show you images for that. And then the patient goes on for the actual treatment. So usually that process between planning and the start of treatment is 1 to 2 weeks, because this is where all the kind of the designing of the treatment and the physics checks and everything happens. The treatment is daily, Monday to Friday, for 5 weeks, sometimes on machine service days, or if there's a public holiday, whatever, that could extend to 6 weeks. Often it's a quick in and out treatment. Patients will be seen regularly by the nurses and the doctor who's supervising their treatment. They would at least get second weekly bloods, particularly as they are on the Xeloda chemotherapy. Following treatment, usually there is a gap between the end of the radiation treatment and surgery. There's a bit of a variation as to how long that gap is, but as a general rule of thumb, the longer you wait, the more likely you are to get, response. But also, you do not want to wait too long that you start running into the problem of post-radiotherapy scarring and fibrosis. So usually 8 to 12 weeks is the time that we wait between the end of radiation and surgery for the long course. During that time at Concord, we often get patients involved in a program called prehabilitation, which is a really important program that patients go through to really improve their fitness in the lead up to surgery. And it's usually led by a dietitian, a nurse, and a physiotherapist. They, go through various instructions with them, education sessions with the nurses, some targeted training exercises to actually help with their fitness to surgery, and that, does improve their surgical outcomes. This is some of the kind of behind the scene work. This is how it looks like, all numbers and quite fancy work, if I can say, to try and design this treatment plan that's quite individualized to the patient. So what we're trying to do is to target the area where the cancer is with a high dose of radiation, where that green is, but also still treat the lymph node areas that we think would be at risk of potential microscopic disease. We treat that to a slightly lower dose of radiation. So we give like a prophylactic dose to some areas and high doses to where the cancer is. We rely on the MRI, on the colonoscopy reports, on the clinical assessment of the patient to come up with this plan. And we've got some really strict criteria as to where that dose should go, what organs around, like the bladder, the small bowel, the bone, everything. There should be, all limited doses to these normal structures to limit toxicity as much as possible. During the journey of radiation for rectal cancer, patients will meet the different teams of radiotherapy, the team members of radiotherapy. So radiation oncologist is the doctor who recommends, prescribes treatment and supervises the whole treatment. I would be, delineating the disease volumes on this, planning CT, review all of that dosimetry and doses and approve the plan, reviewing the patient regularly to check on toxicity. The radiation therapist is the actual person that runs the machine. So this is the machine that we see here. This is called a linear accelerator. This is where patients actually lie down to get the treatment. This is run by the radiation therapist. Also, they are the people who actually design the radiation plan and perform the dosimetry. Medical physicist he probably doesn't meet the patient, but they do a lot of behind the scene work in terms of quality assurance that everything goes to plan, and they do these regular checks for the machines and the plans. The radiation therapy nurses, they coordinate care, they provide education and support for patient. They also monitor them weekly for any side effects. Now, the side effects that I usually counsel the patient about, radiation therapy side effects are often divided into short-term and long-term because body does not forget radiation. So there is long-term impact that could last for decades or forever, so they're permanent. Luckily, the long-term side effects are uncommon. The common ones are the acute side effects, which are often mild and self-limiting. But, there could be grades from 1 to 4, depending on the severity of these side effects. Fatigue is a common side effect to any radiotherapy course, regardless of the body site. But then the other ones are more specific to the site of radiation therapy. Now, because we're treating the pelvis, so anything within the pelvis theoretically can get toxicity from radiation. So proctitis is the term that's used to describe the inflammation, the acute inflammation that radiation can cause to the rectum itself. So this could present with symptoms like discomfort, discharge, tenesmus, and then diarrhea or frequency, urgency, all these types of symptoms. These are often, patients, because they're coming every day to see us. GPs rarely get involved in managing these toxicities, but patients do occasionally go to their GPs to kind of get the additional advice and management of these toxicities. But we often manage these symptomatically with, it could be, local suppositories could be used sometimes if the side effects are severe enough, or for enteritis, which presents as diarrhea, we can use antidiarrheal medications like Imodium or rarely dexamethasone. Sometimes they could get some bladder symptoms such as frequency or urgency. It could get nausea, which is both from chemotherapy and radiotherapy. But, with the more advancement in the techniques that we use, we're seeing less of these side effects because we're able to really shape the radiation beams around the cancer and spare these normal organs as much as possible. So we're not getting as much toxicity as we used to years ago. With the long-term toxicity, I think one of the probably commonest one is the altered bowel habits, which could mean, if they're going on to have surgery and, I think that the symptoms of that overlaps with the ultra-low anterior resection syndrome that Matt talked about. So they could have the urgency or frequency or potentially incontinence, depending on the location of the tumor. Risk of small bowel obstruction is quite small, but it's there. We usually counsel patient about that. This could be managed conservatively or by surgery, depending on depending on the situation. Sexual dysfunction, again, it's for females in particular, I think we counsel them about the risk of vaginal stenosis post-radiotherapy. So the patients will get a specific education about using what we call vaginal dilators after radiotherapy to make sure that this reduces the risk of vaginal narrowing or dyspareunia. Infertility, particularly for females and males as well. Luckily, because most of our patients are, beyond the age of needing to have children, that's not often an issue. But if it's For males, we could refer them for sperm banking before. For females, it's more difficult because the effect of radiation on the ovaries and uterus is permanent and hard to reverse. Insufficiency fracture in the pelvis or the sacrum, this is rare, again, because we're able to get the beans away from the bone, but for patients who are at baseline risk, for example, with severe osteoporosis, they could be at risk of that. Secondary malignancy is a very rare but serious complication of radiation. The risk of that varies depending on how young or how old the patient is. On average, we usually rate quote a rate of about 1 in 1,000 risk of having another cancer because of radiation. This is not often something that happens, quickly. It could take 10 or 20 years down the track, and it's often within the area that's seen the radiation. So for a rectal cancer treatment, it could be, a soft tissue tumor like an angiosarcoma type thing within the pelvis. It could be a bladder cancer or any other cancer within the pelvis. Some other exciting directions on radiotherapy for rectal cancer. There are trials ongoing to look at selective use of radiotherapy, so trying to omit radiotherapy for certain patients and just rely on chemotherapy for the advanced cases. There are trials that looked at escalating the dose, so using really higher doses of radiation, and sometimes with using what we call brachytherapy, which is a special type of radiation that delivers the radiation directly through a machine into the tumor. There's some other exciting things happening with more individualizing of the treatment, using some specific markers on the MRI and the molecular markers to individualize the treatment, and also the exciting trials that look at using immunotherapy in specific genetically abnormal tumors. And that's the end of my talk.
Thanks, Roya. We have quite a few questions in the chat, and possibly for both yourself and for Matt, who I can see still online. The first question is there any actions from the GPs in preparation for this treatment?
Not for the time being, but actually we are trying to get GPs more involved. I think because of the nature of the daily treatment for radiotherapy, patients often, the involvement of my team with the patients is quite close with their daily attendance. So often patients come to us for any issues during the treatment. We usually try to keep the GPs in the loop with the correspondences before and immediately after the treatment. I think if patients, attend or, go to their GP with a potential side effect related to radiation, we definitely would like to know about it and discuss it with the GPs. Would be very happy to discuss it. Often it's a simple fix if it's, a bit of a diarrhea or discomfort or pain. But I think, there's often GPs, I find that there's not a lot of involvement because of the daily nature of the treatment.
Thank you. The next question is the time between planning and treatment similar for public patients of 2 weeks?
It varies quite significantly, and this is a really good question. Actually, in my department, it's often 1 week, which is, relatively quick. In other public departments, there's a wait time that could be, 3 to 4 weeks, or even longer. There is some actions that are being done through the college to really set some guidelines, the Radiation Oncology College, to set some guidelines as to what is an appropriate time frame for patients, and categorizing of the radiotherapy patients to different categories depending on the indication for radiation therapy. But it does vary. It happens to be much quicker in the private. This is a reality as it applies to many other treatment modalities. But often it's a week and more.
Great, that's good to know. Third question is, are patients undergoing radiotherapy a risk to pregnant family members or friends?
There's absolutely no risk. We do often tell patients, because that's a common myth, that radiation, so you won't be lighting in the dark, or you're not radioactive to other people around you, because this is an external radiation treatment. So the beam goes in and out the same second, so it does not stay in the body. So they're not at risk of any radiation to surrounding family members. Unlike certain internal type radiation or nuclear medicine type radiation treatments where they ingest radioactive materials, that they could be radioactive to surrounding people.
Thanks so much, Roya. I have a question that came through at the end of Matt's presentation. So I was wondering if you could answer this question. Is there any relationship to HPV and rectal cancer?
Yeah, so the relation with HPV is with SCC. So anorectal SCC is completely different to adenocarcinoma. So the adenocarcinoma is normal run-of-the-mill bowel cancer, but you can get anal SCC, and there is an association with HPV virus, and also with people infected with HIV also have HPV. And it's important, it's hugely important to know the difference in the pathology of those, because anorectal SCC is a cancer that melts away with chemoradiotherapy, and most of the time surgeons aren't even involved. So yes, there's an association, but only with SCCs.
Thanks to both of you for your presentations. Appreciate the level of detail that was presented tonight. Our third and final presenter this evening is Vesna Dragoje, who is the Director of the Sydney Healthcare Interpreter Service at the Sydney Local Health District, and responsible for providing strategic and operational management, service planning and development of healthcare interpreting services within the boundaries of Sydney Local Health District and Southeastern Sydney Local Health District. She has a passion for language, communication, and their connection to equitable health outcomes. Vesna will be presenting on call communities and lack of access to services, resources, and information. Thank you, Vesna.
Thank you very much, Rebecca. Hello, everyone, and I will apologise straight away. I seem to be losing my voice, or something's happening, so please forgive me. I was asked to speak about equity and access issues for culturally and linguistically diverse patients accessing services with GPs and healthcare providers in the hospitals. So I would like to start by saying I know that I'm speaking to a group of professionals, and, so I'm probably speaking to the converted. However, often there are things that we sometimes forget or dismiss, and this is usually due to time constraints. So I wanted to go through a whole number, some issues that affect culturally and linguistically diverse people. So first of all, we often talk about equity. We all know what the term means, but it means very simply that everyone has a fair opportunity to enjoy good health and to access health services that they need. Now, we're very lucky to live in a country with great diversity. Our diversity is one of our greatest strengths. However, that diversity also brings with it specific responsibilities to ensure that our programs and services are culturally responsive, and to ensure that we consider diverse needs when developing and delivering our models of care that improve equity, access and health outcomes for COLD people across prevention, acute, community-based and virtual care. Now, both Roya and Matthew, and their presentations were absolutely fabulous. I took loads of notes that can help me in my practice in the future. But they both highlighted that early detection is extremely important. And, throughout their presentations, I was thinking, how does this apply to some of our communities? In 2022, the federal FECA, which is the Federal Ethnic Community Council of Australia, identified that there were programs and research implications for COLD populations, and that it was widely acknowledged and understood that the Australian health system does not adequately cater for people who do not have high proficiency in English. Now, when we talk about that, it was interesting. Roya mentioned offering one of her patients the opportunity to go into a clinical trial. Now, I know that according to our data, very few people from culturally and linguistically diverse communities actually attend clinical trials. And there's, I guess, a whole number of reasons for that. Clinical trials are extremely complex processes. And recently what our service has done, we've worked very closely with the Cancer Institute of New South Wales to develop a training program for interpreters across the state to work in cancer clinical trials. So at the moment, we're conducting pilot programs. The feedback from those programs has been very, very good. And what we're hoping will come out of this is that we will have a workforce that is extremely competent to interpret during clinical trials. What we also know is that people from culturally and linguistically diverse backgrounds are a heterogeneous group, and they include temporary migrants. So this is international students that we have within our country, as well as temporary work skilled. We've got refugees and asylum seekers who usually settle through humanitarian support programs. And of course, we've got our permanent residents and citizens of migrant backgrounds. And I think it's extremely important that we understand that we've got these variations in our migration patterns, because they're the different people that we're speaking with and people that we're providing services to. Now, all of these people have diverse cultures, languages, religions, social values, and migration trajectories. So variations include migration patterns, visa conditions, differences within cross-cultural groups and generations in relation to belief systems, expressions of culture, and an individual's connection to culture. All these variables are extremely important for us to understand, because the way that these people will have different experience of health systems within their own communities, but they will definitely have different understanding and experience with health systems in our community, in the Australian community. All of these variables also make reporting on the health needs of cold populations in Australia complex and challenging. The term cold can have multiple definitions in our data sets and can include aspects such as a person's country of birth, their ancestry, where their parents were born, what languages they speak, and their religious affiliations. I guess one of the most important things that we understand is that there can be very large differences within cold groups. So those people born in the same country may not identify with the same culture or speak the same language. And they also, and as I said, they also have very different experiences of our system. So looking at Australia's identity from 2016 to the 2021 census, we can see that there's been a change. We are now bigger and more diverse. Our population has increased by 9% overall. Our first or second generation migrant count has increased, and 22% of our population speak a language other than English at home. That's a 15% increase. So this basically means that 1 in 5 Australians speak a language other than English at home. That's 1 in 4 in New South Wales, and that increases to 1 in 3 in Sydney. These are the people that you're seeing and that you're working with. So if we look at who are our largest groups in the country, India has taken over China in growth, but it's more pronounced in Victoria currently. The trend over the last 10 years sees that the European countries continue to fall. This data is telling and can inform us of age groups that we can expect to be working with. There are 274 languages spoken in New South Wales, and this includes 51 Indigenous languages. The first slide looks at the top 10 languages in the state, while the second slide depicts the top 10 languages ranked by low English language proficiency. And that's extremely important to understand. So limited English proficiency is the inability to read, write, speak, or understand English very well. It is perhaps one of the more obvious and more researched language-related obstacles to health faced by people from diverse linguistic backgrounds. LEP is associated with decreased access to healthcare, worse health outcomes, and worse health outcomes when compared to those without limited English proficiency. The difficulties related to English proficiency or not speaking English as a first language and the healthcare system can apply across the care and prevention spectrum. For example, people with limited ability to read English may have difficulty sourcing, understanding, and interpreting trusted health information. The idea that good health starts with good individual choices is a widely accepted assumption. However, in order to be able to make good individual choices or to be able to participate in our decision-making for the health that we receive, we need to understand the information that we're being given. We need to be able to participate in ensuring that we're making informed decisions. So difficulties understanding verbal and written information, the implications of which can include missed appointments, non-adherence to treatment or clinic procedures, and poor self-care. So when we look at patients with low health literacy, we know that they are more likely to visit emergency rooms and they are less likely to follow treatment plans, and they have more hospital stays and higher mortality rates. So difficulties understanding verbal and written information, the implications, as I said, of which can include missed appointments and non-adherence to treatment, can include the following barriers. So people from cold communities face unique challenges in regard to cancer screening and early diagnosis, as well as access to appropriate treatment. These barriers can include language and cultural barriers, such as not knowing where to seek help or know how to access services. And this is a common theme that we who work within the cold communities very often see. People just don't know where to go for help. There is a sense of cultural isolation and the distress of being misunderstood, a fear of being treated differently, whether that's actual or perceived. There's fear, shame, and stigma associated with cancer, taboos surrounding death and dying, low awareness of the need and benefits of screening, misunderstandings in regards to cancer causes, poor communication between care providers, patients, and family, and of course, hierarchy and limited power in the context of doctor-patient interaction and relationship. The next slide talks about a study that was undertaken by Wollongong University back in 2019. This study wanted to explore participants' experience of each step of the FOBT process. Participants discussed knowledge of bowel cancer and attitudes to screening. The study explored their perceptions towards and usability of Australia's national bowel screening kit with members of migrant communities in the Illawarra, so the Macedonian and Serbian. These two communities make up 20% of the cold population in Illawarra. Some of the comments that came back from the focus groups are following. So there were quite a number of people that mentioned that they needed translations, that they weren't able to read. And so the first barrier was in finding out what this kit was about. They said that we need to get someone to translate this for us. So barrier number one, and this will take time. We all have to call, we will have to call people to help. So people will just throw it to the side somewhere else. And this is what people were doing because they didn't understand it. They also said that because they don't speak English well enough, they were not able to fill out the forms. And even if we did speak English, some things are a little bit too complicated. So it was hard to understand the questions and we can't always get the help in time. There are many people out there in our community who just don't have family members or don't have someone that they could call. On the kit, it also states that if they need any support, that they can call TIS, and that they can find extra information or resources on the website. But many people, especially elderly people, are not computer literate, or they don't have a computer. So that was another issue that came up. And then others also mentioned that because they received the kit from the government, it was a surprise to them. We didn't know what it was when it came in the mail, so we didn't understand that it was important to use it. So these were just some of the feedback that people were providing. So the study found that multiple factors contributed to low readiness and capacity of participants to use the kit. And these included limited ability to read English or translated instructions, perceived lack of endorsement of the kit by GPs because they'd never heard it mentioned before. In some cases, limited belief in the efficacy of the kit and limited promotion in community languages. They suggested that the kit was of poor design and poorly sequenced, and it was difficult to understand, and that the instructions were complex and also a barrier to completion. So some of the feedback and recommendations from the study were that positive messages about bowel screening needed to occur. Sorry, I think I've just missed one of my slides. This is it. Okay, so I wanted to talk about potential enablers. So they found that positive messages about bowel screening efficacy were required, promotion of the kit in community languages, greater access to translated instructions and in-language community education and support, and improved government endorsement would help. But they also said that potential enablers were that doctors and health workers should promote and administer the screening tests so they weren't self-done. They suggested that taking an approach to care planning and communication that was inclusive of family members. And also it was suggested that multi-component interventions, so media plus referrals and support to services would have been useful. They also spoke about the cultural awareness of the healthcare providers that they were working with and found that this was lacking, involving patients in the communication and information sharing, and knowing how to effectively work alongside professional interpreters would have been extremely useful so that they could then receive that information from their GPs and through professional interpreters. So effective communication is the initial step toward person-centered care and shared decision-making. Language and culture interact in complex ways that affect health and one's comprehension. Ultimately, professional healthcare interpreters have the unique ability to assist clinicians in establishing the healing connections that form the foundation of ethical and culturally sensitive care. What we very often find is, so our service, we work within the public healthcare sector. And what we find is that by the time patients have arrived into the hospitals, they haven't really understood a lot of, the issues surrounding their disease or their illness. We found that the feedback that we've received is that GPs tend not to use interpreters within their general practice. I'd be interested to know from you whether that is the case within your own practice. We've also received feedback that when patients have requested to use an interpreter due to the belief that it's going to cost the practice or due to time constraints, it's been suggested that they bring somebody with them. So again, that's been an enormous barrier. Healthcare providers should always request interpreters for cold or deaf patients. They should always address patients in plain language, avoiding jargon, acronyms, and technical terms to allow the patient to have a better understanding. They should limit the information provided and create a shame-free environment. As we mentioned earlier, one of the barriers is about people's perceptions of cancer, especially colorectal cancer. And the situation that we had recently was that we had a patient who had told us that they had liver cancer, and they needed some assistance in getting a referral into one of the hospitals. When the referral was sent in, it was deemed that the liver cancer was secondary. So the cancer had already spread to the liver. When we asked the patient, why they didn't tell us that they had rectal cancer, they said that they were too embarrassed. And they felt that having liver cancer was more acceptable than having rectal cancer, which is really telling, and it's a real shame. So information needs to be given to patients very early on in a way that they can understand through the use of an interpreter. Often patients may visit their GPs on their own, but even if they decide to go with a family members are not the appropriate people to interpret. And that's for a whole number of reasons. One of those is that, as Matthew had mentioned earlier, even though a lot of information can be given, the people that you're speaking with are usually in shock. They're usually very stressed. They're usually very fearful, and all they have heard is the term cancer. And so they don't really take in a lot of information, and that can apply to the family member as well. Family members should be able to participate and to offer support to the patient, rather than having to go through this process of trying to interpret. They may also not have the language necessary to be able to interpret what's being said. I love the way that Matthew did use visual aids to support the message that he was trying to get across, and I found that extremely helpful, as do our patients. So very often we do need to use visual aids to support the message. The human body is incredibly complex, so please don't assume that we all know what you know. We also need to ensure that we're encouraging patients, as well as interpreters when they're at the appointments, to interrupt and to ask questions, because a lot of what you're telling them may not be getting through. It's always recommended that when you're working with a patient whose first language is not English, is to use the teach-back method to confirm whether the patient has understood the information that's being provided. So teach-back is about not saying, do you understand? Because what we find is people will usually nod and say, yep, I understand. But asking them to repeat back in their own words what it is that they have understood, using their own words. What we found is that with people that are illiterate, even in mainstream society, people that are illiterate very often have fabulous short-term memory. So if you ask them to repeat back what you've said, they will be able to repeat it often word for word. Now, that's not an indication that they've actually understood what has been said. So how do you support health equity and healthcare quality and efficiency for COLD patients? I think one of the first things that we very often lack is documenting and identifying patients' needs. So very often we find that when referrals do come into the hospital system from GPs, there is no indication that these people do require an interpreter. So I think that, and by having identified patients who may require an interpreter within your own practice, it enables the frontline staff to know and to be able to organise a telephone interpreter at least when they enter the room, so that there is no time wasted, so that you can then communicate with the patient through an interpreter as soon as they enter. Building a positive patient-clinician relationship in the setting of language discourse is extremely important, and this often includes including family members in the care that's being provided. Often we find, especially with elderly patients, that it is the family members that are making the decisions as to, and family members will often say, oh, I don't know, you need to ask my daughter, or you need to ask my husband. So including family members in their care is extremely important. taking responsibility to navigate and use language services and resources that are available to you. So, and that means by ensuring that you are providing adequate and timely language interpreter services to address the communication barriers that you have with your patient, rather than expecting patients to bring their own interpreter with them. BYO interpreters are not something that we would recommend. Health education and communication resource materials need to be developed and accessed in patient languages. There's a lot of materials and resources out there on various websites, and I believe that that's going to be provided, that you can access, and that can be provided to patients to take home to read in their own language at their own leisure, and they can, try to digest the information that they've been given. Implementation of appointment reminder systems also facilitate the uptake of healthcare. So there are translation appointment reminder tools that can be used. And I believe that that might be on the resources list as well. That's a tool that was originally developed by the New South Wales Refugee Health Service and now sits on the New South Wales Multicultural Health Communication Service website. And this can be downloaded and used as a reminder tool, or to provide people with appointment details in their own language. Community organisations can be pivotal for disseminating culturally meaningful information. So trying to develop those partnerships with community organisations is going to be extremely cost effective. And of course, timely referral and awareness of risk factors. Timely referral, awareness of risk factors, history taking, assessments, none of this can be done without language. So Roya spoke about the process of taking a detailed history in order to be able to, then continue on with, physical examinations and blood collections and procedures that are required. That can't happen without effective communication. So it's really, really important that we're able to ensure that we're communicating with our clients from the onset, if we are, to make sure that these referrals are timely and that people are getting the services. We know, as Roya said, there are, unfortunately, within the public health system, there are wait periods. So it becomes extremely important that we're on top of, getting a proper diagnosis and then the care. I think that one of the other things that are really, really important is culturally competent providers delivering healthcare to our populations. As I said, 1 in 3 people in Sydney speak a language other than English. It's extremely important that we include cold issues in the training or academic curriculum for future healthcare providers for the delivery of culturally appropriate care. And of course, ongoing monitoring of quality improvement initiatives, such as, data collection. And it doesn't matter, even if your practice is a very small one, having a really good understanding of the community that you're seeing, the requirements of that community, and then also being able to, at the ready, have the resources that are required that are going to help you as tools to do your work. So those are things that I think are extremely important. The importance of collaboration, we know that these are really important. In the complexity of the care needs for people with a cancer diagnosis really requires a team-based approach. You all know that, that's why you're here. So the benefits of collaborating at the organisational level, they're at the whole team benefits, and of course the patient and their family also benefits. And I don't need to tell you that. I'm just aware of the time, and I don't want to keep you. So again, language and culture, life experience and beliefs shape an individual's perspective and relationship with the world. Language and cultural differences create barriers to information, and without language, we lose our most effective tool for establishing a meaningful relationship with patients and the opportunity to address individual worries and fears. There are interpreting services. and translation services accessible across the country. So our service, the Sydney Healthcare Interpreter Service, we provide services to the public health sector and across the board. So we work within 2 local health districts and 3 local health networks. There are 4 other New South Wales healthcare interpreter services in the state, and they belong to Hunter New England Local Health District, who look after everything from Central Coast all the way up to the Queensland border and over to the far west. There's Illawarra Shoalhaven that looks after the southern part of our state. And then, of course, there's our service, Western Sydney and Southwestern Sydney, that look after the metropolitan area. The TIS is a service that is available to all general practitioners and medical specialists outside of the public health sector. So TIS National is easily accessible. All general practitioners can access TIS free of charge. And, you know, telephone interpreting is available, as is face-to-face interpreting, and of course, interpreting through video conferencing. These services are available, you know, our service is available 24/7, as is TIS. So there is no reason not to be able to access these services. And Deaf Connect and NABS are the services that are available for our deaf communities. Which of course we also have, you know, fairly large numbers in the Sydney district. There are, if you go onto our website, onto our webpage, we have got lots and lots of information for healthcare providers working with interpreters. There's information about, you know, accessing, there's information about working specifically with deaf clients, and there's also information on how to conduct an effective 3-way interview. So I know that at times doctors, you know, we're all stretched for time, and I know that it can be difficult, but working with an interpreter, and the more you work with an interpreter, it is not time consuming. It doesn't have to be, you know, you might need an extra 10 minutes on top of a lengthy appointment, but it also means that, you know, your patients are satisfied, they're able to participate in the decision making, and they're also able to accept treatment, trust their practitioners and the process, and have improved health outcomes. So thank you.
Thank you very much, Vesna. That was very interesting, and I appreciate the list of resources on that final slide. It's really helpful. A question has come through in regards to booking appointments. Is it easy to organise an appointment for a patient at short notice, say within 72 hours?
Is this for a GP visit?
I'm assuming it's a GP visit, yes.
So for a GP visit, yes, it is. So TIS is, I think they have about a 3-minute turnaround time. So if you know that you have a patient coming in tomorrow at 11 o'clock, when they come in, and if you're running late, you can virtually book, your admin staff can virtually book a interpreter whilst the patient is going into see you. So by the time they sit down and you know, greet them, you should be able to have a telephone interpreter on the line. That can also, video interpreting can be a bit more difficult, and so that could be a pre-booked appointment where you would contact TIS and pre-book a video interpreter. Now, the only problem can be for some languages that might be either in very high demand. So, for example, if you were seeing a deaf patient, there are Auslan interpreters are extremely busy, very high demand, and a very low resource. So those interpreters do need to be booked at least 72 hours in advance, and that's extremely important. But normally for a spoken language, for telephone interpreting, yes, you can usually book somebody, as said, as the patient is literally walking into the door. In the public health system, it can be a lot more difficult, and we need a lot more planning, because we cover, you know, everything from literally from cradle to birth. And as I said, you know, with we cover 120 different language groups, and So we're extremely busy. So we do provide both on demand and pre-booked appointments, but the majority of our appointments are face-to-face ever since we've come out of lockdown.
That's really good to know. Can I also ask a question about access to TIS for allied health professionals? Is that still available to allied
Yes, it is.
professionals?
Yes, it is available. It's available to pharmacies, and now very of recent, it's also available to mental health professionals outside of the public health sector. So, it's very accessible. I think the difference between the TIS interpreters and healthcare interpreters is our interpreters are specialised in healthcare, are provided with a lot of professional development opportunities. So as I said, I was taking a lot of notes because I think it's really important that we can then share this information with our staff as well. TIS interpreters are usually generic, however, extremely professional. Professional interpreters working in Australia are all NAATI certified. So that is, they're certified by the National Accreditation Authority of Translators and Interpreters, and they need to recertify every 3 years like any other professional group, and also have to follow a very strict code of ethics.
That's great. Any other questions before we sign off? Can't see any coming in. A big thank you again to all our presenters tonight and for our attendees for attending tonight's webinar. Just a reminder, if you could complete the online survey that will pop up in your web browser. Please visit our website to view upcoming events, and if you want any further information on the cancer management offered through assessment, which includes GP Can Share, there's some information there on the web page. We look forward to seeing you online soon, and thanks again to everyone.